Today I am going to present a very common congenital anomaly, that is myelomeningocele, and try to focus the management and the prevention of prevention of the myelomeningocele. So, brief review of the embryology, so that we come to know how the spinal cord forms, and in which stage the abnormality of the spinal cord will occur. So, basically, this diagram showing the neurulation process, which start at the third week, in which the neural tube will form. This process is called neurulation. This is a neural fold. This is basically this is a neural plate in which there is a neural a groove, and this is a neural fold on the both side, and then notochord, which control the process of neurulation. On the day 21st, it forms like a tube, and uh, after 28 days, this structure will close to form a complete tube. The failure of this closure of this structure, which results in the neural tube defect, uh, which is a common in the which is a most more common in common cause of the congenital anomalies in the child. So this figure showing there that the normal and the abnormal vertebrae. This is a normal vertebrae. This is a spinal canal in which the spinal cord and the nerves are going out, and this is a spinous process, and this is a normal skin. In this figure, you showed showing that there is a bony defect, and the protrusion of the uh, meninges, the spinal cord, and the nerve roots. And there is a defect of the skin, which result into myelomeningocele. So, how to prevent myelomeningocele is most important thing, that what will cause of course there is a multiple factors, but the nutritional deficiencies is the most common factor. Therefore, it for the which include the folic acid. The in the embryogenesis, there is a formation of neural tube which depend upon the adequate level of folate. The deficiency in the folate level will cause the neural tube defect. So the woman planning to conceive should start folic acid supplementation, so that it decrease the risk of the neural tube defect. This is basically the two types of spina bifida. There are basically two types: spina bifida occulta and spina bifida cystica. In spina bifida occulta, there is a bony defect, but the skin over the defect is intact. In the spina bifida cystica, there is a bony defect and the skin defect. In cystica, there is basically two types. If there is meninges in there, there is called meningocele. If there are meninges plus the neural tissue, then it is called myelomeningocele. So I will try to brief description about the myelomeningocele. So the incidence is 1 to 2 in 1,000 live birth, but it may increase in the nutritional deficiencies, for example, wars, economic disasters. The nutritional deficiency, as I already talked, that the folic acid is the most common factor. Risk is increased if there is a history of myelomeningocele. It is more common in females. There is also a genetic factor. Chromosomal anomalies also contribute to the formation of this congenital anomaly. Maternal obesity and the complicated pregnancies with diabetes also increase the risk of spina bifida. So non-medical causes include in the pesticides, chemical exposure to the radiations, lead, and the tobacco smoking, and drugs which most commonly used are anti-epileptics, including valproic acid and carbamazepine. So the location of the myelomeningocele, which is most common in the lumbosacral region, that is 85%, followed by dorsal and the cervical, that is 10% and 5% respectively. Clinical feature: patient may present it with swelling at the back, with CSF leak, uh, and other associated anomalies, for example, capillary hemangioma. Orthopedic findings, including the deformity of the foot and the asymmetry of the extremities. Neurological findings: weakness of the legs, loss of sensation, and the leg atrophy. And neurological findings including incontinence, neurological bladder, and commonly associated with hydrocephalus. The cognitive impairment may also present cranial nerve deficits, facial deficit, and other systemic anomalies may also associate with this myelomeningocele, and it is commonly associated with ulnar cavity malformation. Assessment: because this is a multidisciplinary approach should be made to manage these patients, which including the pediatrician, neurosurgeon, orthopedic surgeon, urologists, plastic surgeons. So they will combinedly manage this patient. Examination including the head for the head circumference, anterior fontanelle, and and examination of the back for to see the size of the lesion, if there and any CSF leak. Examination of the lower extremities and the neurological examinations are most important. So how will we going to investigate with the patient with myelomeningocele? Prenatal maternal serum alpha fetoprotein may raised in the patient with myelomeningocele, and aminocentesis may also helpful to diagnose prenatally. X-ray, which is less commonly used, but it tell us about the bony defect, and MRI is the investigation of choice for the neurological involvement and the management plan regarding the surgery, and ultrasonography may also helpful. Management of the patient with myelomeningocele: prenatal management, including the intrauterine repair. This is a newer technique, but there is a still controversial. But with this technique, you are going to repair the myelomeningocele intrauterine through intrauterine prenatally in the third semester. Trimester. So there is. What you are going to do is pass the endoscope, and you can repair it easily, repair it with endoscope. So the risk of the benefit of this surgery is that the risk of cavity malformation and hydrocephalus is decreased if you do the repair in prenatally. But the neurological deficits will be the same. There is no neurological improvement if you do this surgery prenatally. So the surgical, the next option is the surgical, which is the closure of the defect and the post operative management. If the myelomeningocele is ruptured, then start antibiotic and closure the defect as soon as possible, because there is a high risk of meningitis because of the CSF leak. If the lesion is unruptured, then there is no need of antibiotics, but cover the lesion with soak, sterile gauze, prone position to decrease the risk of CSF leak, and perform the better to perform this surgical procedure within the 36 hours. The goal of surgery is to free the neural tissue from the dura to avoid tethering out the cord and the watertight closure of the dura and the skin. And the closure does not improve the neurological function of the patient. This should be kept in mind while doing this surgery, and also before the surgery you should also counsel the parents that it will not improve the neurological function. So surgical closure with latex-free gloves should be done, because most of the patient with myelomeningocele have allergic to latex. So and should be closed with within the 34 of after the birth. Post-operative management, including the prophylactic antibiotics, analgesics, and the dressing is also important to avoid the infection. There must be a plastic barrier drape should be placed between the MMC and the anal canal, so that there is the risk of infection. Keep the patient in prone position so that there is less risk of CSF leak, and there is less pressure on the wound. Avoid narcotic analgesics, because in this patient there is high risk of respiratory depression, so avoid narcotics. Regular OFC and the internal fontanelle should also be used to manage post-operatively. Post-operative complication, including early complication, which include wound infection, sign of hydrocephalus, meningitis, and sepsis. Late complication, this is most important and common, is hydrocephalus, carry malformation, tether cord syndrome, scoliosis, and dermoid tumors. Prognosis of this patient, because there is a multiple systemic involvement in this type of this patient, there is the prognosis is not so good. So 90% of the patient has neurological bladder, and 85% has fecal incontinence and dribbling of the urine with crying or movement. 70 to 80% of the normal intelligent. The mortality rate is 15% within the first 6 months, even with aggressive treatment. Thank you.